So my name is Ceri. I'm a pharmacist based in Anarian Bevan Health Board, just next door. So I'm going to talk about antimicrobial resistance, and hopefully, being a healthcare professional audience, people know what I'm talking about. But just in case you don't, then I'm just going to go through a few quick pointers. So whenever bacteria are exposed to antibiotics, they can develop a way to survive the bug, and they can share this resistance with other bacteria as well. And that sometimes results in what you probably know as superbugs, things like MRSA, and sometimes even more resistant organisms as well that are then resistant to potentially all antibiotics. So resistance is actually driven by antibiotic use. So whenever we use antibiotics for any indication, that's putting the patient and the people around them at risk of resistance. Because people can share this. It's not the individual that actually becomes resistant themselves, it's the bacteria that live in and on us that we can share with other people. So just as infection prevention was important with COVID, it's really important with resistance as well. And the problem is that if antibiotics don't work anymore, then common medical interventions such as chemotherapy and some surgeries become too risky to undertake because we wouldn't be able to treat people if something went wrong. And it means that also people will die of infections that are currently treatable. So people are already dying of resistance, but things that we take for granted are going to be okay, such as if we have a cut, for instance, that could be potentially fatal if we don't have antibiotics there. So at the moment, on average, antibiotics add about 20 years to our lifespan. So if we lose this precious resource, then we are going to see a reduction in life expectancy. So some of you might have seen this paper that was published back in January, and it's a fantastic paper because they've done a huge amount of work around the global data of current burden of disease. So what they found from a review of the 2019 data is that there are almost 5 million deaths associated with resistance in that year, of which 1.2 million deaths were directly attributable to resistance. And unfortunately, but perhaps not surprisingly, they concluded that AMR is already a leading cause of death around the world, but the burden is highest in the low resource settings. So you can see from that graph that down the right-hand side, we have got Western Europe, so Wales is sitting down here. Malawi, that we partnered with, is unfortunately up here. The burden of disease is really quite stunning. And when we were in Malawi, we attended one of the medical handovers in the morning, and they were discussing some of the patients that had been admitted overnight. And they had a couple of patients who had relatively treatable conditions like pneumonia that we would be able to treat here that had died overnight because their resistance rates are currently so high. So it's for no... Okay. So there's a good reason that it's called the silent pandemic. Resistance is already here. We are already sharing it. But unfortunately, it is growing, and it's silent because we may already be carrying it within this room, and we don't know it. It's not like COVID, where if you catch it, you're probably going to develop an infection soon. We might just be carrying resistance with us. So it's another COVID-related situation that nobody is safe until we're all safe. And therefore, AMR is a global problem requiring a global solution and global action. So what do? We try and approach antibiotics by a process called antimicrobial stewardship. And it's a huge range of interventions that are aimed at optimizing antibiotic use. So that includes using antibiotics only when necessary. So making sure that we're taking a thorough diagnosis, using diagnostics to make sure that we are excluding maybe viral illnesses where we wouldn't need antibiotics. And also using antibiotic-sparing approaches whenever possible. So for those infections that are self-limiting, actually just giving that self-care advice to people, giving them something else other than an antibiotic to treat that infection that will clear eventually of its own accord. And when we do need to use antibiotics, it's about making sure that we're using the right drug at the right dose, at the right time, and for the shortest possible duration. So AMS in itself involves loads and loads of behaviour change. So this is why empathy is so important in this, because antibiotic prescribing is very much driven by the likes of culture, as we've already discussed today, but also by behaviours, having that kind of doctor-patient transaction relationship maybe as well. So a lot of AMS is about enabling other people, both healthcare professionals and members of the public. And obviously, those of us within the audience fall into both of those categories. So we need to think how we behave differently as a patient as we would do as a healthcare professional. So what we did is as part of the funding programme for Commonwealth Partnerships for Antimicrobial Stewardship, we formed a partnership last year through the THET brokering process. So we formed a partnership between the Pharmaceutical Society of Malawi and the Welsh Antimicrobial Pharmacy group that I'm currently chairing. And there were 3 of us from Wales that were involved, so myself and what affectionately became known as the 2 Charlottes, one of whom is sitting at the back today. And the reason that we actually did this as a nation-to-nation approach is that most health partnerships are based on hospital to hospital. And we wanted to make sure that, AMS is something that needs to be addressed at scale. So we thought by taking a national approach, we can both reduce variation, but also kind of increase the scale and the speed of the work as well. So each country has a national action plan for resistance. So our work was really kind of like helping, support Malawi in implementing that national action plan. And a kind of side benefit that we wanted as well was actually showcasing pharmacists as leaders in the field, because as antibiotics are a drug-related issue, it's an ideal opportunity for pharmacists to take the lead. And within Malawi, pharmacy is a relatively new profession. They've only actually had their own school of pharmacy for the last 8 years. So it's a real good opportunity to actually show what pharmacy can do. So we developed the project together and applied this time last year, and we were awarded £20,000 for a 6-month grant to train pharmacists as AMS leads. So the aims of the project was really to try and take a sustainable approach, not in us training everybody ourselves, but actually upskilling the pharmacists to then cascade that training on the ground. So we chose 2 tertiary hospitals to work with, and part of the application required Ceri objectives. So we actually kind of chose to try and demonstrate female role models as well, not only in ourselves actually kind of being there, but also training female role models as well to cascade that training. We wanted to make sure that we got a baseline, so we actually undertook some global point prevalence surveys as well to see what usage was like in the hospitals, because we were going into a situation where we had no existing data aside from just rough usage data. We developed a toolkit to support pharmacists to review and optimise antibiotics at ward level. And that was the original aim, but what ended up happening was we kind of broadened it to be broadly applicable to other healthcare professionals as well, to help that kind of like widening of the scope. And we developed training slides and workshops for that cascade. And we actually kind of like put aside a little bit of funding as well to make sure that all healthcare staff of all grades, genders, ethnicities could actually attend those training as well. So we chose 2 hospitals to partner with, so Mzuzu up in the north of Malawi and Cymru Central in Lilongwe, the capital. And as part of the project, I think one of the big things was actually establishing that partnership itself, not just doing the work as well. So even just from the process of identifying volunteers, both from Wales and from Malawi, applying for the grant, implementing the project, and then actually undertaking a visit in February of this year. All of that we've done together. So we have a collective responsibility for the partnership, and we undertake all our decision-making jointly at our weekly Zoom meetings. And as a result of this, we decided to put in a submission for the Hub Cymru Africa Awards, and we were highly commended in the Best New Partnership category this year in recognition of the strength of the partnership despite the short length. So coming back to one of the earlier presentations talking about kind of, can you actually justify in-country visits? I would strongly recommend that. I think there's a certain amount that you can gain from having conversations, trying to map the processes and understand from a distance. But when you actually go and see with your own eyes what's happening, it's very different. So for everything that you know and you've kind of gone through in theory, you learn something else as well that complements it in practice. So as part of our visit, we met with key stakeholders. What we've tried to do as a partnership is align ourselves to other work that's going on in the field at the moment. So there's a Fleming Fund country grant that we met with their team to make sure that their work in strengthening microbiology lab capacity dovetails with what we're doing with teaching staff and making sure that people are aware of the ability to request microbiology tests and the need to do so as well. We also met with the likes of medical directors, and it was great, having that one-to-one kind of conversation with them. And the medical director in KCH in Lilongwe actually said, actually, it's really nice. You're not coming in, just telling us what to do and then going away again. You're actually asking what we need, and you're offering to work in partnership with us. So, that was really, really important in having those kind of like meetings and those face-to-face conversations that maybe wouldn't have happened or wouldn't have been as optimal on Zoom or Teams. We also took the opportunity to observe doctors' handovers, join in on ward rounds, and walk around the departments just so that we could see all the processes and kind of understand it fully ourselves. And it was also interesting to see the different way in which kind of pharmacy roles operate within Malawi. So for instance, because there's very, very few pharmacists, there's quite a lot of support staff. But we've identified that as a potential opportunity for the future, that if we upskill those support staff, it releases the pharmacy time to actually go away and do other things. And whilst we were there as well, we also helped assist with some of the baseline data collection. And as I say, not only is it great to be able to make sure that our interventions are tailored and are kind of fit for purpose, it also gives us bi-directional learning to bring back to NHS Wales. So one of the things that we came across was this kind of stock situation, and the stock situations that we came across really kind of, I think, were a lot worse than we were anticipating. So this is meropenem, which is very much a last line antibiotic. If you need this, it's probably, you're either going to have this or you're going to die. So this is one of the ones that we tend to try and keep on the shelf if at all possible. But within NHS Wales, we use this day in, day out. This was the stock that they had for KCH in Lilongwe. So they had 11 vials for a 1,000-bedded hospital. That stock would have lasted one patient 2 days. So they have to be really, really kind of careful with their stock management, and therefore they will only give this to infections where susceptibility to this antibiotic is confirmed on a microbiology result. Now actually, we looked at that and said, that's a really good way of doing it. We need to bring that back to Wales so that we actually kind of like do this as well, so that we have coordinated action. But it really kind of seeing those empty shelves for ourselves was really, really powerful in saying, actually, what we think we want to do, we can't. We need to think differently about the way we approach this. And in terms of empathy, sometimes things are really well intended, but they don't actually work in practice. So this is Hope, one of our pharmacists on the team, and that's a whole wall of medication that had been donated from another country. So done with the best of intentions, but unfortunately very short-dated stock. It was stock of cardiovascular drugs and other drugs that we have a great need for in the UK, but because of life expectancies, there's much less of a demand within Malawi at present, although it's going to grow. And that means that they've got huge corridors and kind of shelves of expired medicines that then need to be disposed of. So actually, with the best of intentions, people are actually causing a problem in having to kind of make these hospitals actually dispose of all these medicines. So in terms of the project, we got through a lot in a very short space of time. So we undertook those baseline global point prevalence surveys, and Charlotte, who's sitting at the back, led on that piece of work. And it was a huge achievement even just to get the ethics committee approval through. Now, what that did is gave us data to kind of work against, so basically allowed us to target some interventions as to, actually you're using a load of IV medicines, why couldn't we get some of those patients off IVs onto orals, which frees up your nursing time as well. So, there's, if you don't have that data, you can't make those decisions. We also trained the AMS leads on development of key performance indicators, and also developed that toolkit that I was talking about as well. So that's a 35-page document, which is basically a manual of how to approach a patient that's got an infection, what you need to think about, and how to manage that infection. And then after that, after we trained the lead pharmacists, then they cascaded the training to 120 healthcare workers locally. And KCH in Lilongwe have actually adopted that package of the toolkit and the training as standard for their hospital going forward so that they can continue that cascade training. And then finally, we had a little bit of extra funding at the end from THET, which we used to buy some TVs to actually put in the patient waiting areas, because public awareness and engagement is really, really important in trying to change behaviours. And so actually they've got videos showing that were developed by the Commonwealth Pharmacists Association on what antimicrobial resistance is and how we can change our behaviours to actually try and address the problem. So those have now been installed into KCH and Mzuzu as well. And then because of the short length of time of the project, we're currently still in our assessment phase. So we're just getting back the results of the kind of the follow-up assessments at the moment. So of course we did come across challenges. It was the first time that we'd all worked together, and there was a lot of groundwork to do for the partnership as a whole, as well as actually delivering the project. COVID very much delayed our travel. We did wonder whether we were going to be able to travel at all, but we did end up travelling back in February. It did mean that we had planned to do some follow-up data collection, but we didn't get round to that. And it's meant that everything else has kind of been delayed as well. Unfortunately, because Malawi are going through a bit of a review at the moment, they're restructuring all their stewardship teams. So us actually developing some action plans with the hospitals and key performance indicators didn't actually come to fruition, but hopefully they should be embedded in the kind of new structures that are being built at the moment. And it was really, really important, as I said before, in building those relationships with key stakeholders. Some of the wider challenges that we couldn't really address that easily were kind of the supply chain issues, in terms of one of the main antibiotics that was coming in that had a dependable supply chain was ceftriaxone, and that was the one that there was most resistance to, because that was what was used day in, day out. But actually that was the reliable one that was available to use, so that was what was used whether the patient was going to survive or not. And similarly, there's some of the approaches that we might have taken within Wales in terms of changing to different regimens or kind of combination treatment that's just not feasible, because the nursing staffing levels are not there to be able to actually administer those medicines more than once or twice a day. But just to finish off, the future hopefully is really, really bright for this partnership. So what we're planning to do is disseminate the results, both within Malawi and kind of on a wider scale, and hopefully publish the results, because the evidence base around AMS and around pharmacy in Malawi is very, very scant, so we hope to kind of start to try and address that. Applications opened yesterday for another round of funding, so that it's going to be all systems going, getting that application in. But what we hope to do is replicate what we've done in the 2 tertiary hospitals in the other 2 tertiary hospitals, so that we've covered all tertiary hospitals in Malawi, and then also try and start rolling that out to other hospitals as well, maybe using a hub and spoke model. We hope to try and get the Malawian team over to Wales, just so that they can actually see the way that we work differently, maybe give them some ideas as to how they could use their technicians differently and release some pharmacist time, and continue that bi-directional learning, because they might actually come along and say, why are you doing this? Why don't you do something that's much more simple and efficient? And hopefully we will try and get our training materials validated as well, so that people can actually kind of get CPD credits for doing so as well. The Welsh members of the team are currently completing a Chief Pharmaceutical Officer Global Health Fellowship, and we're hoping that that's going to give us the knowledge and skills to really kind of like lead this and keep going with it. And during the lunch hour, we were actually late having lunch because we were meeting with the Chief Pharmaceutical Officer for Wales, talking about how we can use this as a way in to do more work. So, in terms of promoting the profession and kind of developing medicines management across Malawi. And basically, as I said before, the Malawi Pharmacy Association, they are such a young and dynamic group of people. They are really inspirational. I think all of us from Wales, went there and said, wow, we want to be like them. And it's great. We want to be able to enable them to lead the profession forward and also teach us while they're doing so as well. Thank you very much for listening.
Ceri, fantastic presentation. Thank you very much for that. I was very interested in that point about where you use data to guide decision making, very foundational to what you did. The points prevalence survey, what outcome were you measuring the prevalence of? Was it antibiotic prescribing?
Yeah.
Or okay.
Antibiotic prescribing, IV proportion of use, etc., duration of therapy. Simple markers, but a good kind of rough estimate.
Okay, so not making any judgments about inappropriate antibiotic prescribing, but just sort of using proxy indicators of what that might be. Yeah?
There are some of those questions in there, yeah.
Excellent.
So it's a really good kind of grounding, and that's one of the things that we were discussing in our meeting yesterday. Do we actually need to publish that as a baseline for Malawi as well?
Yeah, fantastic, but excellent piece of work. Thank you. Thanks for sharing that.
Thank you.
Thank you for that fantastic presentation. Just out of interest, what is the Malawian government or health department doing in terms of regulation of pharmaceutical reps? Because having worked in neighbouring Tanzania, I was profoundly aware that was a huge problem in our hospital because there wasn't any regulation. So we had reps coming from different countries bringing meds that are no longer recommended, have been pulled off license, and really just turning up with all sorts of, counterfeit papers, dodgy leaflets, incorrect data, and, speaking to doctors or health professionals without sufficient knowledge of how to check the evidence, just because that wasn't included in their training, and therefore going, oh, this is a great drug. This will help everybody. And actually, it's a drug that's been removed from the majority of countries because it's an awful drug. And, it has a massive influence in some areas. So I don't know about Malawi. I was just interested to hear.
To be completely honest, I don't know about the regulation of reps at all. It's not something we've discussed, but we have had a number of conversations about supply chains, and that does seem to be relatively well regulated in terms of it's done through the Ministry of Health, and there's a central medical stores, it's like its own health board within Malawi. So there's central medical stores, and they are kind of set up next to the hospitals, and everything comes through that route. So from what we've seen, it seems to be relatively well done, but actually one of the members of the team has just recently changed jobs, and he is now working with the Ministry of Health on supply chains. So it's great to have those kind of links into that, but something I'll raise. Thanks.
In a number of African countries, there are a high population of people that actually self-medicate. They buy their drugs off the counter.
Yeah.
How do you intend to incorporate that cadre of people in your work?
That is something that we would like to work towards, because obviously we saw those kind of, traditional herbalists that we saw in the last presentation, and a lot of people were self-medicating through those routes. I think at the moment we're trying to kind of pick off the low-hanging fruit that is some of the easy wins. That is a huge area that we want to move into, and we've been discussing whether we do some scoping work around that, maybe as part of the next project. But it is a huge issue, because that goes through to public engagement and understanding and education, etc. So there's so much potential work that could be done around that. if you've got any ideas about where to start, I would be really willing to hear. Thanks.
Just on one of your slides, I'm just really curious. You said something about using female role models.
Yeah.
What's the thinking behind that? I'm just curious.
It was basically, in terms of the health profession, the pharmacy as a profession in Wales, we're very much kind of, female-led, and kind of like, there's a disparity that very much in favour of women. Within Malawi, it seems to be a little bit more kind of like male balanced. So really the idea was actually just to kind of give some female role models within the health environment, and just, to provide that little bit of diversity, where we've got a lot of kind of like men, actually making sure that some of the role models are female, just to inspire other women. Thank you very much.